Hi everyone! Today we're gonna be talking about electrolyte imbalances. So, there are two electrolyte imbalances that we're gonna be talking about. It will be sodium imbalances and potassium imbalances.
Electrolytes imbalance. Electrolytes. Elements or minerals found in bodily fluids that become electrically charged particles, namely cations or anions. Responsible for many activities of the body including heart automaticity, nerve impulses, movement of water and fluids, and chemical reactions. It also allows cells to generate energy and maintain cell wall stability. And hormones produced by the kidneys and adrenal glands control most electrolyte levels. Reasons for electrolyte imbalances. First is kidney dysfunction. Second is lack of water due to dehydration or diarrhea, and side effects from medication. So abnormalities occur when electrolyte concentrations are imbalanced between intercellular and extracellular fluids. So the first electrolyte is sodium. Sodium transmits electrical impulses in heart and nervous system. It also regulates water distribution and fluid balance to the entire body. It also helps regulate acid-base balance. So examples of food rich in sodium includes cheese, ketchup, soy sauce, canned foods, and many more. So the normal levels of sodium in the extracellular level is 135 to 145 mEq per liter, and the intercellular level is 10 to 12 mEq per liter. So sodium imbalances is the changes in water, not in sodium, which results to hypovolemia or hypervolemia. So there are two most common sodium imbalances: hyponatremia or low in sodium, and hypernatremia or high in sodium. Hyponatremia is most common electrolyte disorder. It is more common in very young or very old. Hyponatremia, sometimes caused by water intoxication wherein there is too much water intake that causes sodium dilution in the blood and will overwhelm the kidney's compensation mechanism. It can also be caused by a syndrome of inappropriate antidiuretic hormone secretion or the SIADH, but it is often caused by increases in antidiuretic hormone or the ADH, and other causes includes profuse diaphoresis, vomiting, diarrhea, draining wounds, excessive blood loss due to trauma or GI bleeding, and some medication side effects and renal disease. There are three main types of hyponatremia. First is hypovolemic, which is the most common, wherein total body water decreases, total body sodium decreases, and extracellular fluid decreases. For the euvolemic, total body water increases, total body sodium remains normal, and the extracellular fluid increases minimally, and there is no edema. For the hypervolemic, the total body sodium increases, total body water increases, and the extracellular fluids increases markedly. So the pathophysiology for hyponatremia. When there is too much water intake, it results to water intoxication, wherein sodium dilution in the blood occurs. It also causes the kidney to retain sodium to compensate for the non-renal fluid loss such as vomiting, diarrhea, and sweating. And it can also be caused by the syndrome of inappropriate antidiuretic hormone, wherein the hypothalamus produces sustained ADH, or the tumor produces ADH-like substances, which results to inappropriate excretion of sodium. The signs and symptoms of hypovolemic hyponatremia, or low volume and low sodium. The most common includes dry mucous membranes, tachycardia, decreased skin turgor, and orthostatic vital sign. For the signs and symptoms of hypervolemic hyponatremia or high volume and low sodium, it includes rales, S3 gallop, jugular venous distension, and peripheral edema as well as ascites. For the diagnostic findings, it includes blood studies from serum electrolytes, which is less than 135 mg per liter. For the medical management, it includes treatment of underlying condition and sodium replacement in normal diet or NGT or in lactated ringer solution or isotonic solution. And sodium must not be increased in 12 mg per liter in 24 hours to avoid neurologic problems. And another medical management includes water restriction. For the pharmacologic therapy, it includes AVP receptor antagonists, which stimulate free water retention. It also includes IV conivaptan hydrochloride, which is a limited treatment with moderate to severe symptomatic hyponatremia, and as well as tolvaptan, which is indicated for hypervolemic and euvolemic hyponatremia. For the nursing diagnosis, first is risk for electrolyte imbalance or hyponatremia related to diarrhea, vomiting, renal dysfunction, treatment-related side effects such as medication, gastric suctioning, electrolyte-free intravenous solution, and water intoxication. For the nursing management, it includes monitor intake and output, and calculate fluid balance and weigh client daily. Second is to note for signs of circulatory overload as third is identify client at risk for hyponatremia and the specific cause such as sodium loss or fluid excess. And the fourth is encourage fluids and foods high in sodium such as meat, milk, beets, celery, eggs, and carrots. Use fruit juices and bouillon instead of water. The fifth is monitor serum and urine electrolytes and osmolality. Next is provide or restrict fluids, and it also depends on fluid volume status. And next is administer medication as indicated. The second sodium imbalance is hypernatremia or the high in sodium. It is very rare to see 145 mg per liter, and 50% of cases are fatal at that level. Hypernatremia also leads to intercellular dehydration because water follows sodium into extracellular spaces. As the saying goes, where salt goes, water follows. So hypernatremia is more common in very young, and women who have poor nutrition have poor milk production for their newborns. The causes for hypernatremia includes dehydration, wherein there is too little water, or water loss can occur from vomiting or diarrhea, excessive sweating, or from drinking fluid with high salt concentration. It can also be caused by decreased thirst drive in elderly, dementia patients, and newborns, and decreased water intake that leads to free water deficit and leads to high sodium. And lastly, diabetes insipidus. For the signs and symptoms, it includes restlessness, change in mental status, irritability, seizure activity, nausea, vomiting, increased thirst, ataxia, tremors, hyperreflexia, flushed skin, increased capillary refill time, decreased cardiac output related to decreased myocardial contractility. For the diagnostic findings, blood studies for serum electrolytes wherein it exceeds 145 mEq per liter, and for the serum osmolality, it exceeds 300 mmol per liter. For the medical management, hypotonic electrolyte solution, which helps lower serum sodium level, and isotonic non-saline, which water needs replacement without sodium, and desmopressin acetate, which treats diabetes insipidus. For the nursing diagnosis, risk for electrolyte imbalance or hypernatremia related to diarrhea, vomiting, diabetes insipidus, renal disease, fever, profuse sweating, high protein diet, side effects of medications such as osmotic diuretics. So for the nursing management, it includes monitor intake and output and specific gravity, assess the presence and location of edema, and weigh client daily. Next is assess skin turgor, color and temperature, and mucous membrane moisture. Next is the client needs to avoid foods high in sodium such as regular canned vegetables and vegetable juices, processed foods, snacks, and condiments. Another is encourage increased oral and IV fluid intake. And monitors serum electrolyte, osmolality, and arterial blood gases as indicated, and restrict sodium intake and administer diuretics as indicated. Potassium. It is the second electrolyte imbalance. It is most concentrated inside the cell. It regulates muscle tissue contractility, including heart muscle. It helps control cellular metabolism, converts glucose to glucagon for fuel, and regulated by kidneys, excess levels removed by feces and sweat. And serum potassium level controlled by sodium-potassium pumps, which pumps sodium out of cell and allows potassium back into the cell. Normal levels for potassium is 3.5 to 5 mEq per liter. Potassium imbalances. There are two types as well. The hypokalemia, which is low in potassium, and the hyperkalemia, which is high in potassium. Hypokalemia causes includes nausea, vomiting, diarrhea, diabetic ketoacidosis, laxative abuse, and diuretic medication. Other causes includes high corticosteroid levels, insulin use, magnesium deficiency, medicines used for asthma or COPD, acute kidney failure, and high aldosterone level. Pathophysiology for hypokalemia. Decreased potassium levels in the extracellular space will require a greater normal stimulus for the polarization of the membrane in order to initiate an action potential. Almost all of the manifestations that occur with hypokalemia results from the slowed neuronal excitability and its consequent effect on muscle function. The signs and symptoms includes muscle weakness, aches, cramping, paresthesias, confusion, fatigue, syncope, hallucination, low blood pressure, palpitation, nausea, vomiting, and diarrhea, polyuria, and UA with low specific gravity, and EKG changes, wherein there is U wave, increased QT interval, flat T wave, and depressed ST segment. For diagnostic findings, blood studies for serum electrolytes is less than 3.5 mg per liter. The ABG, wherein correction of metabolic alkalosis raises serum potassium level and decreased replacement needs. Correction of acidosis drives potassium back into the cell, resulting in reduced serum levels and increased replacement. For the medical management, it includes treatment of underlying. For the nursing diagnosis, risk for electrolyte imbalance or hypokalemia related to diarrhea, vomiting, diabetic acidosis, renal failure, high sodium diet, starvation, profuse sweating, treatment-related side effects such as diuretics, TPN, and some antibiotics. The nursing management includes note for signs of metabolic alkalosis such as tachycardia, dysrhythmia, hypoventilation, tetany, and changes in mentation. Also, monitor level of consciousness and neuromuscular function, noting movement, strength, and symptoms. Another is encourage high potassium diets such as oranges, bananas, tomatoes, coffee, red meat, and dried fruits. Discuss the use of potassium chloride salt substitute for a client receiving long-term diuretics. Also monitor the rate of IV potassium administration using microdrop set or infusion pump. Observe for side effects and provide ice pack as indicated. Monitor laboratory result as indicated and administer potassium orally or intravenously. Next is hyperkalemia or the increase in potassium. The causes is often related to renal issues such as acute failure, stones, inflammation, transplant rejection, and etc. Potassium levels build up because it can't be excreted in the urine. Another cause is using potassium supplements and medications such as steroid use, NSAID use, and some diuretic use, and ACE or the ACE inhibitor. Other causes is severe burns or trauma injuries, overuse of salt substitute, rhabdomyolysis, metabolic acidosis or ketoacidosis, wherein the acidosis and high glucose level work together to cause fluid and potassium to move out of the cell into the blood circulation. Pathophysiology. Increased levels of serum potassium results in depolarization of the membrane potential of cells. This depolarization opens some voltage-gated sodium channels, but not enough to generate an action potential. After a short while, the open sodium channels inactivate and become refractory, increasing the threshold to generate an action potential. This leads to the impairment of neuromuscular, cardiac, and gastrointestinal organ system. The signs and symptoms. It can be life-threatening if sodium causes a potentially life-threatening heart rhythm. The EKG changes with peak T waves, prolonged PR interval, wide QRS complex. Other signs and symptoms include nausea, fatigue, muscle weakness, tingling sensation, bradycardia, and weak. Diagnostic finding includes blood studies for serum electrolyte wherein it is greater than 5 mg per liter. For the medical management, diuretics. Body gets rid of potassium mainly in urine. Intravenous therapy. Extremely high potassium levels need immediate treatment. IV infusion of calcium to protect heart. Next is an infusion of insulin that helps move potassium into the blood cells. Inhalation of an asthma medication called albuterol to further lower the potassium levels. The medication management, stopping or changing certain blood pressure medications or other drugs that raise potassium level. And it also includes potassium binders, which binds to excess potassium in the intestine, and dialysis, which helps your kidneys remove excess potassium from blood. Nursing diagnosis. Risk for electrolyte imbalance, namely hyperkalemia related to renal disease, treatment-related side effects such as cytotoxic drugs, NSAIDs, diuretics, potassium-containing medication, massive transfusion with bank blood. So for the nursing management, first is monitor heart rate and rhythm. Be aware that cardiac arrest can occur. Next is monitor respiratory rate and depth, and encourage deep breathing and coughing exercises, and elevate the head of the bed. Also monitor urine output. Next, encourage frequent rest periods. Assist with daily activities as indicated. Also encourage intake of carbohydrates and fats and low potassium foods such as pineapple, plums, strawberries, carrots, cauliflower, corn, and whole grains. Also identify and discontinue dietary sources of potassium such as beans, dark leafy greens, potatoes, squash, yogurt, fish, avocados, mushrooms, and bananas. Also review drug regimen for medications containing potassium or affecting potassium excretion such as spironolactone, hydrochlorothiazide, amiloride, and penicillin G. Also monitor laboratory results such as serum potassium and arterial blood gases as indicated, and administer medication as indicated. Also provide fresh blood or wash red blood cells if transfusion is indicated. Also infuse potassium-based medication or solution slowly, and prepare for and assist with dialysis. So the references includes the following.
That's all, and thank you for listening.